नमो नमः। परम आयुर्वेद आयोजित और पंचकर्मा महर्षि वैद्यराज गोगटे पुरस्कार प्राप्त चरक संहिता अध्ययन अध्यापन तद्विद्य संभाषा इस उपक्रम के 290 पुष्प में वैद्य महेश भुजबल और मैं वैद्य सारिका भुजबल उपस्थित सभी मान्यवरों का सहर्ष स्वागत करते हैं। आज के प्रमुख वक्ता आदरणीय परम गुरुवर्या वैद्य विशाल तुर्लापट्टी महोदया जी का भी विशेष स्वागत। आज के पुष्प का आरंभ हम धन्वंतरी स्तवन से करेंगे।
नमामि धन्वन्तरि मादिदेवं सुरासुरैर्वन्दितपादपद्मम् लोके जनार्दन भयमृत्युनाशनम् धातारमीशं विविधौषधीनाम् शङ्खं चक्रं जलौकामृतघटं चारुदोर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिर्हृद्यां सुखपरिविलसन् मौलिमं भोजनेत्रम् कालाभोजोज्ज्वलाङ्गम् कटितटविलसत् चारुपीताम्बराजम् वन्दे धन्वन्तर्यम् निखिलगगना प्रौढदावानीलीलम्।
धन्यवाद। कोल्हापुर में सुप्रसिद्ध ज्ञानी, अध्ययन अध्यापन एवं तद्विद्य संभाषा में माहिर आदरणीय परम गुरुवर्या वैद्य विशाला तुर्लापट्टी महोदया जी का स्वागत करने हेतु मैं वैद्य अनिता जी से अनुरोध करती हूँ।
हेलो, धन्यवाद सारिका जी। नमस्कार। डॉक्टर सारिका जी एवं महेश जी के अथक प्रयत्नों से चरक अध्ययन की बगिया का यह 7वां साल चल रहा है और इस व्याख्यान माला की खूबसूरत माला का यह 290वां पुष्प है। आज इस आयुर्वेद की ज्ञान गंगा में एक और धारा जुड़ने जा रही है और वह है आदरणीय वैद्या विशाला तुलापट्टी मैम। विशाला मैम प्रसूति तंत्र तथा स्त्री रोग में MD है और PhD कौमारभृत्य में की है। आदरणीय मैडम बेहद कुशलता से पिछले 25 सालों से यशवंत आयुर्वेदिक कॉलेज एंड PG सेंटर कोल्हापुर में स्त्री रोग तथा प्रसूति तंत्र में प्रोफेसर तथा HOD का पदभार संभाल रहे हैं। आदरणीय विशाला मैम यह उत्कृष्ट वक्ता है और इनके वाक कौशल के साथ इन्होंने ढेर सारे गेस्ट लेक्चर भी विविध विषयों पर दिए हैं। इनफर्टिलिटी, इंडोमेट्रियोसिस, योनि अर्श, उत्तर बस्ती, ऐसे अनेक क्लिष्ट किंतु रोचक विषयों पर आदरणीय मैम के व्याख्यान हुए हैं। आदरणीय मैम की जिज्ञासु बुद्धि तथा खोजी प्रवृत्ति होने की वजह से उन्होंने अनेक रिसर्च पेपर भी पब्लिश किए हैं, जैसे कि डायटेटिक्स प्रोटोकॉल इन प्रीनेटल एंड पोस्टनेटल पीरियड, उत्तर बस्ती, रिकरेंट प्रेगनेंसी लॉस, ऐसे अनेक महत्वपूर्ण विषयों पर मैम के केस पेपर्स हैं। हम सभी जानते हैं कि आयुर्वेद शास्त्र कहता है कि उत्तम वैद्य कैसा होना चाहिए। उत्तम वैद्य को अपने समकालीन शास्त्रों का भी अध्ययन करना चाहिए। इसी शास्त्र वचन को ध्यान में रख के मैम ने कॉल्पोस्कोपी की ट्रेनिंग लेकर एक महत्वपूर्ण वर्क कर रहे हैं। कॉल्पोस्कोपिक इवैल्यूएशन ऑफ सर्विक्स एंड सर्वाइकल स्क्रीनिंग विथ मैनेजमेंट ऑफ प्री मैलिग्नेंट लीजन बाय आयुर्वेदिक सिस्टम, ये एक बहुत ही अनोखा और अच्छा विषय है जिस पर मैम काम कर रहे हैं और इनकी ट्रेनिंग भी मैम ने ली हुई है। आज के मैम का व्याख्यान का विषय है आयुर्वेदिक अप्रोच इन द मैनेजमेंट ऑफ रिकरेंट प्रेगनेंसी लॉस। हम सभी में से बहुत से वैद्य ऐसे होंगे कि जिन्होंने इस सब पे काम भी किया है और कर भी रहे होंगे और करना भी चाहेंगे, पर हर जगह से हमें कुछ नया सीखने को मिलता है और जब तक हम कुछ नया नहीं सीखते हैं तब तक हम आगे नहीं बढ़ते हैं, हमारी प्रगति रुक जाती है। तो आइए आज हम सभी एकाग्रता से आदरणीय विशाला मैम के अनुभव के बोल सुनते हैं और उसे अपनी प्रैक्टिस में समाविष्ट करके मैम का आभार व्यक्त करते हैं। धन्यवाद।
Thank you, madam, for the nice introduction and very kind words spoken on me. Shall I take over the presentation?
Yes, ma'am.
Yeah, thank you. At this outset, I'm highly thankful to these organizers of Param Ayurveda चरकस अध्ययन अध्यापन तद्विद्य संभाषा, Dr. महेश भुजबल जी और डॉक्टर सारिका भुजबल जी for offering me to share some of my views what I am doing in my clinical practice, and also I am very much blessed to be a part of this noble cause of treating people with the Ayurvedic system. So very humbly I am bowing my head to Lord Dhanvantari for making me to avail some of the knowledge. I think maybe in the vast samhitas what is explained or what is said, only that is an ocean and only one drop I am utilizing for the society. So I bow my head to the all acharyas also who has given this knowledge for us. And at this outset I want to express my sincere gratitude to my management and my institute, Yashwant Shikshan Prasarak Mandal, the Honorable Secretary Dr. Jain Patil sir, and also our Dean, Yashwant Ayurvedic College and Postgraduate Training Center, Dean Dr. Honorable Dr. M.M. Godbole sir, and all my colleagues, my department colleagues, PG scholars, all the paramedical staff, everybody is involved in this. Is a teamwork what we are doing, and I am here to share some of my views which we are practicing at our institute, Yashwant Ayurvedic College. So the title for today's presentation is Recurrent Pregnancy Loss, an Ayurvedic Approach. So this will be a totally an integrated approach particularly for understanding according to the present day scenario. Even we need to understand this pregnancy loss in the present modern terminology also, what it could be. So this will be the presentation outline. Introduction about recurrent pregnancy loss, and Ayurvedic conceptual understanding of RPL, and also line of treatment, and finally the conclusion. So the recurrent pregnancy loss, when we call this as a recurrent pregnancy loss, so pregnancy loss before the viability of the fetus. So according to RCOG guidelines, it is 24 weeks. But again, FOGSI, the Indian Gynecologist Association, it is considered as 20 weeks. So because it depends again the survival or the viability of the fetus according to the infrastructure, management capacity, climatic conditions, and the nutritional status prior to the expulsion of the fetus, that is a maternal nutritional status, all come together. So we in India, we can consider it as 20 weeks. So up to 9 weeks, we consider it as early pregnancy loss. So what the RCOG guidelines for criteria of miscarriage is gestational sac should be more than 20 mm when we measure it or when we go through an ultrasound diagnosis. So embryo with crown length of more than 6 mm, when there is no cardiac activity, we we consider it as a pregnancy loss. So RPL, that is recurrent pregnancy losses, it should be 3 or more than 3 consecutive losses with less than 20 weeks of gestational age. So incidence is roughly about 1% in the population. But again, according to the etiological factors, different etiological factors, incidence will be varying according to the particular etiology. So majority of women does not exhibit any cause for this recurrent pregnancy loss. So spontaneous recurrent abortion occurring consecutively 3 or more occasions is categorically divided into 2, primary and secondary. Primary is before the birth of a viable child, that is, there is no viable child existing for that particular female, then we call it as primary. Secondary is after the birth of a viable child, that is, one viable child will be there whether live or dead. That's not a considerable point here, but one viable birth of a child followed by the recurrent pregnancy loss, we consider it as a secondary RPL. So the difficulties, why we have to discuss and why this has become a challenging subject nowadays is the difficulties what we encounter in treating recurrent pregnancy loss is generally more than one cause will be operating and deficient protocols. So everywhere the protocol is not one and equal because multiple factors are the causative factors. Sometimes no cause will be identifiable. So there is no protocol, particularly what has to be given as a guideline. And there is no empirical, there is only an empirical treatment. That is, as per the demand is there, as per the condition comes in front of the obstetrician, the treatment will be going on. And lack of larger randomized trials. So there is, for any treatment guideline or the protocol to come out to the, which is useful to the society, some good number of randomized trials have to be taken place. But in this area, there is much deficiency is there in this studies of randomized trials. And one more challenging point for this RPL is more than 50% fall in unexplained category. So here, there we as an Ayurvedic obstetricians, we can do better because the modern conventional science always look for a cause and treatment. So if the cause is unidentifiable, then treatment may also be in a confusion state. But for Ayurvedic obstetrics, because the basics of Ayurvedic dosha siddhanta, dhatu sapta dhatu siddhanta, all the basic principles, if we look at, there are some categories which fall under Daiva Karana, that is unexplained category. So in that also we have got an efficient management strategy. So we can treat better than the conventional modern science the recurrent pregnancy loss. . So 2 or more consecutive losses, as I told you, according to RCOG, and according to the American Society, it is again 2 or more, less than 500 grams or 20 to 22 weeks, which is more suitable by WHO for the Indian scenario. And it is a heterogeneous condition because multiple operating factors, etiological factors are there, poorly understood pathogenesis, and standard investigative protocol fails in more than 50% of the cases. So coming to the evaluation, a meticulous obstetric history and past history of any surgical, medical illness, family history, but in some families, some tendencies of this autoimmune disorders will run. So any such family history of recurrent pregnancy loss has to be inquired. Personal history, any addictions like alcohol, smoking, or some drug addictions, these things are also to be inquired, and exposure to some chemicals in the working occupational area. Sometimes some drinking water has got a very high amount of metals. So is there any such exposure is there that has to be checked out, and a meticulous physical and local examination has to be carried out. The build and calculation of BMI, that is the height and weight of the patient, has to be checked to see the body mass index and development of the breast. So this will give an indication that what are the factors which are operating behind, because a very less BMI or a very high BMI, both are the contributing factors for the pregnancy losses. So everything counts right from the gait of the patient when she comes into your OPD till the examination, which includes perspicuum and pervaginal examination, and after that some helpful investigations. So the suspected etiologies are anatomical factors, categorized it is into different levels: anatomical factors, genetical factors, infective agents, immune factors, antiphospholipid syndrome, inherited thrombophilic defects, endocrine factors, and epidemiological factors. These are the some of most important causative factors of the recurrent pregnancy loss. So coming to the maternal causes, uterine structural abnormalities, that is Mullerian duct abnormalities, are the major contributing factor for this recurrent pregnancy loss. For example, bicornuate uterus, septate uterus, this will cause implantation problem, and the embryo that is implanted can get aborted without, because there is no proper place for it to develop or for its growth or for the proper implantation. So in these conditions, we have to go for surgical correction only, because this is a structural abnormality. So the role of treating this type of patients conventionally, either medical treatment is not of having any importance. So this is the reason why I'm insisting is always evaluate the factor, then only proper treatment can be given. It is not about how we treat, it is about how we diagnose and how we clinically evaluate the patient. So this is more important, because once the case comes to you, you should assure by all the ways. There should not be any enigma in treating the patient, even in diagnosis. Before treatment, the patient or herself or the attendants will ask you first, what is the diagnosis? So without having that clarity in the diagnosis, then the treatment also will not be complete and patient will not have confidence, because already they will be in a lot of mental trauma, repeated pregnancy loss. And when they feel that you are able to come to a conclusive point where the problem is lying, then they will develop confidence in you. So if it is taking a much more time, maybe another 6 months additional or 1 year additional, they will stay with you. If you are lacking the clarity of diagnosis, then definitely patient will try to avoid your treatment. And the most common thing everybody will say is, if you speak about recurrent pregnancy loss, is the role of TORCH, toxoplasmosis rubella, cytomegalic virus, and herpes simplex. But the recent studies are proving for recurrent pregnancy loss, TORCH has not got any role in causative factor of this RPL, and some infections in the mother. that is a pregnant lady, any local pelvic infections or systemic infections also can lead to pregnancy loss. And the endocrine problems, thyroid, hyperprolactinemia, corpus luteum insufficiency, and genetical factors. Genetical factors like aneuploidies, triosomies, monosomy, triploidy, and balanced translocations, that is called commonly mosaicism. So the missing of the chromosomes or adding additional chromosomes, single gene disorders. So in these conditions, why the pregnancy loss occurs is it is a nature's gift, we have to say. When there is some abnormality, that will fall from the place. So even you can see in the nature also, if a mango tree is giving some hundreds of thousands of flowers, only some hundreds will become small fruits. But from there again to develop into a full-fledged fruit, it will be remaining only 50% or less than that many times. So rest of the things will have some abnormality and they will fall themselves from the root. So this chromosomal anomalies are also like that, which will operate mainly in the first trimester of pregnancy, that too before 8 weeks. So definitely if any patient is coming to you with recurrent pregnancy loss history in the early pregnancy, definitely suspicion has to be raised regarding this triosomies, and proper karyotyping should be done both the couple. And some thrombophilias will also operate, and immunological, which is the most challenging part for the present medical science to treat the recurrent pregnancy loss when immunological causes are operating. And finally, the unexplained category, that is, there is no proper cause found why the pregnancy loss is occurring. So this, I need not repeat what is this triosomies and balanced chromosomal translocations. This is all about the additional and missing chromosomes in the embryo. So there is a variation of 12 to 16% of what you call this anatomical, including maternal abnormalities, as a causative factor for the this recurrent pregnancy loss. So when you come to the anatomical abnormalities, Mullerian duct anomalies, intrauterine exposure of diethylstilbestrol. This is one major concerning factor when a female fetus in the intrauterine life is exposed to DES, when mother is taking DES for the sustaining of the pregnancy from 19, as far as I remember, from 1972 onwards, the American Drug Regulation Society has marked this DES as a contraindicated drug in pregnancy. So at present, we won't see much cases of DES intrauterine exposure, but previously it was also one causative factor. It can cause Mullerian duct anomalies, as well as if the female fetus is survived, some adenocarcinomas are expected, and recurrent pregnancy loss, infertility is also expected. And one more anatomical cause commonly we see cervical insufficiency or os insufficiency, what we call incompetent os, and uterine artery related. So sometimes these abnormalities will uterine artery, lack of proper endometrial supply with this blood supply of this uterine artery can lead to recurrent pregnancy loss. Leiomyomas, that is fibroids which are located in the endometrium, and bigger size fibroids in the myometrium also can lead to pregnancy loss. Isherman syndrome, which will be having extensive fibrosis in the endometrium, will not allow the implantation to occur, so which leads to pregnancy loss. And adenomyosis, cervical insufficiency, of course the same causative factor. And in the endocrinal area, luteal phase deficiency. Particularly this luteal phase deficiency, you see more in the infertility treated conditions, particularly with the ovulation induction protocols. So in this ovulation induction protocol, there is a probability of insufficiency of the corpus luteum producing progesterone, so can lead to luteal phase deficiency, shortened luteal phase. So the sustaining support of progesterone will not be there for the embryo. So it can lead to the early pregnancy loss. So the same LPD can be expected in PCOS also, and hypothyroidism also one cause which can be having luteal phase deficiency, and glucose metabolism abnormalities can be seen both in hypothyroidism and diabetes mellitus, which will hamper the nutrition of the fetus. And hyperprolactinemia also will not allow survive the fetus sustaining of the pregnancy. Lack of progesterone will be there, so which can lead to pregnancy loss. Infections like chlamydia, listeria, so this is 0.5 to 5% causative factors. This is called PID, pelvic inflammatory disease. So most common organism is chlamydia. So it's better to rule out with the previous history of PIDs, like history, meticulous history taking will help, particularly the features of excessive white discharge, PV, dyspareunia, painful sexual intercourse, irregularity in the menstruation, excessive bleeding. All these will give lower abdominal pain, a dull pain in either both the iliac fossa or unilateral. So this will give an indication that the patient might have got chlamydia. And immunological causes is blocking antibodies deficiency. These blocking antibodies are very important to prevent the immunological reaction, because always a fetus is a foreign body to the mother, but there is naturally a blocking antibody that is present which will prevent the recognition of the fetus as foreign, so it will not allow any adverse reaction to happen. But the deficiency of these blocking antibodies will result in rejection of the fetus. And anti-trophoblast antibodies, anti-thyroid, altered immune regulation, this all will be a contributing factor for the pregnancy loss. So this is one of the picture of septate uterus. Most common anomaly which is seen in 55% case. You can see there is a complete T-shaped inversion of the fundus. So this is a common abnormality. This is a septum you can see here, which is seen in the hysteroscopic picture also. So 25% of early abortions are caused by this, and 6.2% of late abortions and preterm labors also. So this will hamper the implantation and further survival of the fetus. So when you come to the immunological causes, there are two categories, autoimmune and alloimmune. Autoimmune is for the self tissues of the particular person. Alloimmune is like for the fetus. It is different immunity that will be shown towards some external agent or fetus or any foreign agent. So directed to self tissues is autoimmune, directed to foreign tissues is the alloimmune. So commonly autoimmune disorders you can see in systemic lupus erythematosus, antiphospholipid antibodies, and in the alloimmune, abnormal immune response to fetus is seen. So this immunological mechanism of RPL is excessive cytokines will be produced, which will be result into antiphospholipid antibodies, and thrombophilia like condition will be developed, which is also genetic, that is clotting mechanism will be affected here, which will hamper the nutrition to the fetus. So antiphospholipid antibodies, not much studies in Indian population were done. It's generally, most of the times it's overdiagnosed, not meeting strict laboratory criteria, and improperly collected samples will give a false positive result. So coming to the thrombophilias, increased arterial and venous thrombosis, which result to the hypercoagulability of the blood, and there is a deficiency of proteins involving in this coagulation. So because of this, there is a hypercoagulability status that is seen, and because of that, there is hampering of the uteroplacental circulation, which is affecting the fetal nutrition and can leading to the fetal death. So the role of the phospholipids is, these phospholipids will hold the dividing cells of the fetus or the trophoblast, and growth of the placenta will be promoted by phospholipids and filter the nourishment from mother to fetus. If mother is taking some harmful substance also, that will be prevented to reach to the fetus because of the filtration mechanism done by the phospholipids. And again, the same thing, the waste from the fetus is effectively transported to the mother circulation. So if there is any deficiency in this phospholipid, there are some anti-phospholipid antibodies are present in the mother, then this whole mechanism will be stopped. That is, there is no proper growth of placenta, fetal nourishment will not be effective, then leading to the both first and second trimester abortions. So how these antibodies are detected in the blood of the mother? So prolonged activated partial thromboplastin time is the indication for this detection of or presence of this antiphospholipid antibodies. So generally 2 positive tests should be present in 12 weeks apart, and this will result if present into vascular thrombosis. And because of this vascular thrombosis, inefficient circulation will be there, that will be affecting the trophoblast function, which gets inhibited, and it will start creating the inflammatory responses at the maternal fetal intersurface. So these inflammatory responses play a major role in causing the abortion. So thrombosis of uteroplacental vasculature target the trophoblast, causing an impaired trophoblastic invasion. So which is most important, proper trophoblastic invasion of the decidua is very important to make the proper blood supply provided to the fetus before the complete formation of the placenta, and this also can result into conditions like pregnancy-induced hypertension, improper invasion of the trophoblast. So because of this inappropriate secretion of human chorionic gonadotrophin will be there, lack of HCG and growth factor, so inducing a syncytial trophoblast apoptosis, self-destruction or death of the syncytial trophoblast, and an inflammatory response via complement activation at the maternal internal fetal surface is seen. So this is a pathophysiology behind the development of vascular thrombosis and inflammatory reaction at the trophoblastic surface. So they also target the vascular endothelium and cause abnormal formation of the spiral arteries. So these spiral arteries are very important in the penetration of the decidua to form a proper trophoblastic body, but this will get affected because the internal endothelium of the spiral arteries will be affected and it cannot penetrate the decidua properly. So coming to the pathophysiology of alloimmunity, normally at the pregnancy, there will be a presence of antigen blocking antibodies. So this is a nature's gift. Otherwise, the fetus is a foreign for the mother and it will be recognized as a foreign body and there will be an antigen antibody reaction. But this is a normal pregnancy. This will be prevented by the antigen blocking antibodies. But so in some couples sharing the same human leukocyte antigen, this antigen blocking antibodies will be inadequate. So in which conditions we see this couple sharing same HLA? Most probably in the consanguinity couples. But it's not a rule that only in consanguinity, that is very nearly blood related couple in the first degree relation cousin, second degree, but also in some couples who are not related by blood. There is no first degree relation, still they can share the same human leukocyte antigen, which if it is present in the couple, then this can block the antibodies. So these blocking antibodies will be inadequate and that can result into the rejection of the fetus, which is alloimmunity. So in these couples, HLA cross-matching has to be done with the husband lymphocyte and wife serum. If it is present, transfusion of the husband lymph in a dose of 10 ml in intravenously, intradermally, 1 ml it has to be given to prevent the alloimmunity in such conditions. So in the conventional science, management of recurrent pregnancy loss, what are the probable management strategies we can see? First one is anatomical surgical correction in case of septate or bicornuate uterus, etc. And preconceptional counseling is very, 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 very important because there are so many conditions, like for example, you have to match the HLA human leukocyte antigen, you have to check the endocrine abnormalities, You have to check any autoimmune probabilities. These all will be done only in the preconceptional period. Once the lady becomes pregnant and when comes to the gynecologist or obstetrician with a past history of recurrent pregnancy loss, very less we can do. So always a preconceptional counseling, particularly immediately after one episode of pregnancy loss or 2 episodes of pregnancy loss, proper counseling should be done, and these couples should be encouraged to take a preconceptional counseling. So in the preconceptional counseling, supplementation of folic acid to reduce the hypercoagulability status, it will be helpful. And supplementation of natural micronized progesterone in the luteal phase will help in preventing some LPDs or luteal phase deficiencies, and going for the glucose tolerance test before only, which will help in any glucose metabolism abnormalities or insulin resistance which is present, which is causing the pregnancy loss. And if it is early pregnancy loss, particularly in case of there is first degree relation or case of family history of chromosomal anomalies, aneuploidy screening by karyotyping is very important in both the couple. So if it is coming to the insufficiency of os, surgical correction with the encirclage as os tightening has to be done, and uterine artery Doppler for the early presence of diastolic notch, which will indicate uteroplacental insufficiency. So this will help in treating the patient in an advanced stage. So normally, if there is antiphospholipid antibodies present, immunological causes, most common treatment that is given in the conventional science is supplementing the female, that is the pregnant female, right from the onset of the pregnancy with 75 mg ecosprin, low dose ecosprin once daily, or in some higher degree of cases, low molecular weight heparin as a prophylaxis, 20 to 40 mg subcutaneous once daily will be given. And APL with recurrent thrombotic events, therapeutic dose of low molecular weight heparin and warfarin is also given to prevent the hypercoagulability and placental insufficiency condition. So these are some of the researches which have been done on the psychological factors, how they operate, particularly some meta-analysis also was performed using random effects model with effectors weighted, sizes weighted by the sampling variance. The risk of miscarriage was significantly higher in women with a history of exposure to psychological stress. So this is where our Ayurvedic intervention will be more helpful. So what are the investigations we have to do in this case of RPL? So generally there is a common saying, what mind does not know, eyes cannot see. So the understanding of the concept, understanding of the diagnostic previews should be in the brain of a treating obstetrician. Then only we can advise for proper investigations. So in the preconceptional period, anatomical 2D scanning or 3D ultrasonography has to be done to rule out the proper anatomical abnormalities. Sonohistography, which will help in determining any internal endometrial abnormalities. Laparoscopy, SOS if needed, and genetically karyotyping has to be done. Glucose tolerance test to rule out early diabetes mellitus. Thyroid function test, HbA1c, HIV-VDRL to rule out infections in the maternal, and antiphospholipid antibodies in the activated prothrombin time. If it is exceeding 25 to 30 seconds, it has to be suspected, and presence of anti-nuclear antibodies and thyroid antibodies. These all will give an indication that what could be the probable cause of RPL. And cervical swab has to be taken in case of recurrent leukorrhea, so to rule out Listeriosis and chlamydia infections. And incompetent os, mild mid-luteal phase serum progesterone, if there is less than 10 mg per ml, you have to suspect LPD, luteal phase deficiency. So in this case, you have to give progesterone, and if it is an incompetent os, I have already mentioned about it, what to be done. And serum prolactin, sperm DNA fragmentation, which is also major role in causing the early pregnancy loss. So these are some of the studies also you can see which have been taken with the fragmented DNA may alter sperm function, resulting either in a failed pregnancy or in infertility also. So these are some of the sperm studies, DNA studies that have been done, which will be suggestive that DNA fragmentation of the sperm is very important factor in causing the recurrent pregnancy loss. So risk factors: maternal age more than 35 years, paternal age more than 40, smoking, alcohol, excessive use of caffeine, obesity, PCOS. So some important points regarding the immunology in pregnancy. Alteration in maternal uterine immunity lead to disruption of the delicate balance of cytokines. So these cytokines are large group of proteins, peptides, glycoproteins secreted by the immune cells. And this increases the production of cytokine, accelerate the parturition mechanism. So we can consider it as a defect in the AMBU, which is the one of the Garbhasambhava Samagri. So best immunomodulator is progesterone. This is the best immunomodulator to protect the pregnancy, we can say. There is fetal maternal interface action. The prevention of the fetal maternal interface adverse action will be given by the protective mechanism, will be given by the progesterone. So if it is deficient, then it will be losing in the protection of this immunomodulator function. So we can consider it as a Pradushta Artava. And progesterone blocks the mitogen stimulated lymphocyte proliferation. So mitogen is one type of peptide which help in protecting this antibody reaction. So this progesterone blocks this mitogen stimulated lymphocyte proliferation. So if this proliferation is allowed, it can lead to miscarriages. So this progesterone will block these peptides. So lacking of this progesterone or deficiency, again considered as Pradushta Artava, can lead to again miscarriages. And modulates, also progesterone modulates antibody production and reduces pro-inflammatory cytokines. So this is all the role of Artava or progesterone, which will Dhaturupa Artava, which will protect the pregnancy. So disruption of the normal CD4 T helper cells and uterine natural killer cell activity and a TH imbalance in the endometrium could lead to implantation failure and pregnancy loss. This is a cell-mediated immunity. So this is one of the immunological function in the pregnancy which will be deficient when there is deficiency of progesterone, which will be leading to the pregnancy loss. So when you see post-pregnancy loss features, what happens at the site of the implantation? Increased inflammatory cell infiltration at implantation site, increased fibrin deposition on decidua, thromboembolism of decidual vessels, inflammation and coagulation leading to the, already led to the recurrent pregnancy loss. So please remember these points because this will be adding to the Ayurvedic management, pre-conceptional management, keeping view in these points. Increased inflammatory cell infiltration at implantation site, increased fibrin deposition on decidua, thromboembolism of decidual vessels. Unless and until this is not repaired, we cannot go for the next pregnancy. So coming to the Ayurvedic approach, there is a data here presenting treated cases from 2019 to 2013 to 2019. Out of 9 cases, there are combination of idiopathic without any established causative factor, and particularly 2 or 3 cases which having low BMI and RH negative. Of course, that is not a contributive factor in these cases, but low BMI definitely is a contributory factor, and slightly raised thromboplastin time, maternal abnormal karyotyping, Escherman syndrome, and single tube block with previous ectopic pregnancy. So these are some of the recurrent pregnancy loss landed in our hospital and treated effectively with the protocols, with Ayurvedic protocols, and all of them have gone for a full-term delivery only. But a lady with maternal abnormal karyotyping, though she conceived, death of the child at 8 months after the full-term LSCS she has delivered. So the cause of the death of the child was not established, but probably some abnormal chromosomal pattern was identified by the doctors who have treated that child. So adopted treatment in these cases, what type of treatment we have adopted? So this first is before pregnancy. Immediately after the pregnancy loss, again I am going back to this. So this is a point to be treated immediately after the pregnancy loss. Increased inflammatory cell infiltration at implantation site, increased fibrin deposit on decidual thromboembolism of decidual vessels. So this has to be corrected with the Ayurvedic treatment. Then only the lady has to be allowed for next pregnancy. So immediately after the pregnancy loss, what we have to do? So the textual reference, one side is there, you can see, and the adopted treatment, what we have adopted. So it's basing on the textual reference only, but only thing is some modulations have been changed. So in the text, it is given that Garbhakosta Vishuddhi. I am sorry here because my laptop is not supporting the Devanagari script, so I have to type in English only. Sorry for the inconvenience. Garbhakosta Vishuddhi purpose, Madhyapan or Tiloddalaka Yavagu has to be given. And Lagupancha Mula Siddha Ruksha Peya after this Yavagu. And then Lavana Sneharahita Peya has to be given. So it has to be treated almost like a Sutika only. So Kledata Amapachana has to be done, Kledahara Chikitsa has to be done, and Shroto Shodhana Chikitsa has to be done. So Dosha Dhatu Parikleda Sosharde Vidirityayam, according to Ashtanga Sangraha, this all the management has to be done for the purpose of Dosha Dhatu Parikleda Soshanardham. And then Kleda Shuddhi also has to be done with this mechanism. Then followed by Snehapana, Basti Chikitsa, Deepaniya, Pachaniya and Jivaniya Dravyas, Madhura, Brahmana, Vatahara Dravyas. So this will help in regulating the vitiated Apanavata and also increases the vitality of Rasadhatu and Majjadhatu, which will help in the next pregnancy to be continued properly without any hampering the pregnancy growth. So because this is the step 1 to last step, you can see there will be Dosha Dhatu Parikleda Shoshana will be done, and then also Amapachana will be done, then will be Brahmaniya and Jivaniya, Rasayaniya Chikitsa is done. So all the ways the doshas are tackled here. But what is adopted in the treatment? Is it the same way? Because we cannot give Madhya and we cannot do all the things that is said here. So practical approach purpose, what we have done. So we have given after the pregnancy loss, whenever the patient reported, may not be immediately, but after 4 weeks or 6 weeks, whatever the time, we have started with initially Dashamula Arista in a dose of 10 ml twice daily in the Apanakala with equal water. So the purpose of giving the Dashamula is, it is got anti-inflammatory, of course, it's a potential Vatahara, Vedana Shamaka, Shroto Shodhaka. So to understand in the concept of present science, anti-inflammatory action it has got, though the site of pregnancy loss inflammation will be very well cleared with this Deepana Pachana and Vedana Shamaka. So this will also help in digesting the ama, the endotoxin or the adverse immunological factors that are present in the patient. Next, Ruksha Sveda. So Ruksha Sveda, the purpose of doing Ruksha Sveda is Kleda Shuddhi. For the purpose of Kleda Shuddhi, Ruksha Sveda is given. So that can be given with Valuka Sveda or with the salt also. Ruksha Sveda can be given. And this has to be done after the pregnancy loss. So after 6 weeks post-pregnancy loss, then till that period, no Snehapana is advised. So after 6 weeks of pregnancy loss, Snehapana should be given for 7 days. Any Vatahara Sneha like Mahanarayan Tail can be given, Bala Tail can be given, or Gogruta, but it should be A2, that is Deshi Gogruta only. It has to be given 10 ml. Then followed by Matra Basti with any Vatahara Taila. So particularly what I prefer is Dhanvantara Tailam, and internally Mahadrakshadi Churna 5 grams with milk twice daily has to be given. So this Mahadrakshadi Churna is taken reference from a local text of Andhra Pradesh that is called Basavarajiyam. That is one important text which are having very good preparations for this pregnancy loss. So this is manufactured by Chintaluru Pharmacy in Andhra Pradesh. So this has to be given 5 grams with milk twice daily, followed by some good Rasayana drug like Ashwagandha has to be given. Next is correction of the sources, that is Shad Bhava Suddhi. What are the sources that are present in the female for the production of the offspring? All this correction of the sources has to be done. So this, under this process, the text has advised Putriya Vidhi. So under this Putriya Vidhi, Evam Jata Rupavantaha Sattvavantaha Chirayushaha, according to Sushruta. So this is, if this Putriya Vidhi is done, Rupavanta, Sattvavanta and Chirayusha, a very healthy, long-living child is born. So this Putriya Vidhi has to be done. So under this Putriya Vidhi, Shodhana Chikitsa for the couple has to be advised, and particularly for the male, Madhuraushada Siddha Samskrita Grita has to be given before Shodhana, and also Kshira. And for the female, Masha Taila is preferable. And also along with this, in the Putriya Vidhi, there is a mantra prayoga. If any couple who are interested, this mantra chikitsa also can be done. So in the Charaka Chikitsa Sharirasthana, it is given Ahirasi Ayurasi Sarva Vetaha Pratihasi. So this mantra chikitsa will be helpful in continuing the pregnancy without any intervention. So what in our protocol we are giving this mantra chikitsa, I'll let you know. So under the Shodhana chikitsa, the most ideal chikitsa that is to be done is Virechana for the couple, followed by Yoga Basti. Dashmula Eranda Yoga Basti is most suitable one, and followed by internal medications like Gokshura, Ashwagandha. For this, all this combination will help in Bija Shuddhi. So initially, Artava, that is the oocyte and the spermatozoa, will get cleared of all the abnormalities. Then for the Kshetra Shuddhi, Jirakarista and Dashamularista for the female. This is particularly for Kshetra Shuddhi. Jiraka is considered as Garbhashaya Shodhakara Dravya. So any Kshetra abnormalities, maybe some type of inflammatory development in the endometrium, some type of what you call excessive cell infiltration, leukocyte infiltration, or because of the immunological responses, and also endometrial receptivity decreasing. So this kind of abnormality will be tackled with this Kshetra Suddhi. And internally, Trikatu Churna with Swarna Bhasma, or if the patient is not affordable, equally you can use Swarna Makshika Bhasma also, along with Nagakeshara Churna. So this is for the preparation of Kshetra. So this you can see in the Chakrapani commentary. For Chakradatta, this Nagakeshara Churna with Swarnamakshika Bhasma or Swarna Bhasma preferably is used internally in a dose of 3 grams for the preparation of the Kshetra. And then followed by Kashaya Basti, Dashmula Matra, and Dashmula, you can give Matra Basti with Mahanarayan Tail or Balatail, and Dashmula Eranda Kashaya Basti, and also supplemented with Yoni Pichu with Balataila or Dhanvantara Taila, and followed by further for further Kshetra Shuddhi, you have to give Uttarabasti. So the most important combination you have to give is Gugulu Tiktaka Grita. So this Gugulu Tiktaka Grita will help in Lekhaniya Guna. That is, the endometrium which is unhealthy will be getting scraped off, and also mixed with the Kashmiri Taila or Kashmiri Gruta can be given, and also Panchatikta Gugulu Gruta with Dadimadi Gruta. So these two also can be used alternatively, and this will help in treating the endometrial receptivity will be increased, and the abnormal immunological inflammatory responses will be cleared off with this formula of Uttarbasti. And finally, for the correction of the Ambo, Rasayana Chikitsa has to be given. So give the Rasayana like Amlaki Rasayana, Ashwagandha, Shatavari, anything you can give. So with this, we have seen correction of all the 4 sources, Kshetra, Bija, Ambu, all Shuddhi has been done here. So post-conception in this recurrent pregnancy loss, what we have to give? Garbhasthapaka Chikitsa has to be done and incorporate Garbhini Paricharya. So whatever the Garbhini Paricharya that is advocated by our Acharyas, right from the first month of the pregnancy to the 9th month of the pregnancy, I have not included here because just mentioning as Garbhini Paricharya, because everyone know what is advocated in the text Garbhini Paricharya, that has to be given. And Masanumasika Kashaya, if can be advised by Shushruta, can be given, which will help in sustaining the pregnancy. And the same Mahadrakshadi Churna in the preconceptional period what we have given, that can be continued throughout the pregnancy. So some of the supplementary medications to reduce the hypercoagulability of the serum, we have to give Madhu and Adraka. It's a blood thinner. Like almost you can see the action of this Madhu and Adraka. If you give in a dose of 10 ml 2 times daily from the day of conception till 36 weeks, it will almost like work like an aspirin. So you can supplement along with the routine Garbhini Paricharya, Madhu and Adraka. And first 3 months of the pregnancy along with routine Garbhini Paricharya gives Varnamakshika Basma 125 mg twice daily with Madhu, and Dhatri Loha till the onset of labor, and that is in a dose of 250 mg dose, 2 tablets twice daily, and Draksha or Dradimadi Gruta 5 mg once daily. So if you increase the, it is 5 grams actually, or 1 teaspoonful by mistake it is given 5 mg. Always Gruta has to be given, or Lehya has to be given in a dose of 5 grams or 1 teaspoonful. With milk it has to be given, Kshira Sahita. So Draksha and Dadima both are rich in nitrous oxide as well as salicylate. So both will help in maintaining the continuous uteroplacental circulation without affecting because of the vasodilatation. So Dadima is also helpful in preventing the pregnancy-induced hypertension-related complications. So either Draksha or Dadima both have got the same property. This can be given. So this is along with the routine Garbhini Paricharya. So coming to the mantra prayoga, which mantra is more effective? There is a what you call a stotra or a stanzas which will be 9 lines of stanza, that is called Sashti Devi Stotra, and one more is in the Tamil Nadu, it is more popular, Garbharakshambika Stotra, and Vishnu Sahasranama Ahalya Krita Sri Rama Stotra. So this again I will take an opportunity to present this here because many number of patients have got benefited along with the recitation of these stotras, but I am not insisting that whoever who is having belief in this can go forward, or any other religions also, whatever the mythological or whatever the religious practices they will do, they can be carried on. So it's not like only this has to be done, because this I have implemented in some of the patients, and we have taken a study also on this. It is very encouraging continuously reciting these stotras during the pregnancy period will help in sustaining the pregnancy. So some of the references you can see here, the vibrations from the mantras have the power to rearrange molecular structure. So each sound has a distinct vibration, and as a result, each mantra has a different effect. All sound affects molecular structure. Furthermore, all thoughts, feelings, words, and actions impact consciousness. So this will help in the proper psych or manasika sthiti that will help in continuation of the pregnancy. So effect of mantras on human being and plants. There is a publication also you can see in Ancient Science of Life. The author, during his various experiments on plants, found that these, from the stage of seedling to the maturity, are affected by certain types of sound waves, and especially the mantras. So this study reveals that the plants have shown a positive response to the type of particular sound waves regarding the growth, their efficacy in curing the diseases also. So this is a scientific proof that mantras will definitely help in sustaining the pregnancy. So this is only a synergistic effect along with our regular treatment. So some of other references like oxygenate the brain, reduce heart rate, blood pressure, get cured by many ailments, create calm brainwave, nitric oxide also will be more released in the body. So these are some of the important references, scientific analysis of mantra-based meditation and its beneficial effect. And you can see many publications on this. So it will also help in arterial vasodilation, which is a very important point to increase the blood flow to the placenta, which will help in sustaining the fetus. So probable action of all these together is, when it comes to the genetic, that is bija dosha, immunological causes, ambu, etc., and antibodies in the maternal circulation, implantation defects, kshetra, all are tackled by the so-called protocols what we have discussed now. So for the chromosomal abnormalities, bija shuddhi, shodhana we have taken, and for increasing the endometrial receptivity, Uttaravasti we have done, and for treating the antibody abnormality, that is clotting in blood vessels, with the Rasayana Chikitsa, which comes under the Ambu abnormality, which with the help of this, correction of nutrient deprivation will be provided, that is Upasneha will be provided, which will help in preventing the fetal death. So this to sum up the Ayurvedic concept of recurrent pregnancy loss, Achaturda tato masat prasave garbhavichuti tatah sthira sharirasya patah panchama shashtayo. So in the 4th month we call it as a garbhashrava, and 5th and 6th it is garbha pata. So whatever it is, it comes under pregnancy loss, and some other conditions like apraja, putragni yoni vyapad, garbhasravi vandhyatva, these all comes under recurrent pregnancy loss. So the 4 mahabhutas excluding the Akash Mahabhuta, when they will activate this, which are the contributing factors of this, which are coming from Matraja and Pitruja, and also from Rasaja and Atmaja. Rasaja here is innate immunity, which is present in the Matraja Bhava or Pitruja Bhava, which will help in preventing the immunological abnormalities, and Atmaja Bhava is the chromosomal abnormality prevention. So this normalcy of this Rasaja, Atmaja, Matraja, Pitruja Bhavas contributing to the 4 Mahabhutas will lead to the development of a healthy embryo when we do all this Shodhana Chikitsa and other protocols. So Chetanaya Hetu Bhutaya Yavat Garbha Prasava Kala Avastitam Chetana Avastitam Anyataha Kuttita Vishirnam Syat, according to Sushruta. So this is indicating Chetanaya Hetu Bhutaya Yavat Garbha Prasava Kalam Avastitam. When a proper combination of this Mahabhutas is present, the Chetana will be present in this along with this 4 Mahabhutas, and because of this the Garbha will be continued till the Prasava Kala. Otherwise, Anyataha Kuttita Vishinnam Syat. If it is not present, it will be having abnormality or it will be going for the loss. So initially this can be understood that the trophoblastic function, which is producing this progesterone, which is helping the sustaining of the trophoblastic function because of the production of progesterone from corpus luteum. So this itself we can understand as Chetana. So when this Chetana is present initially, the pregnancy will be sustained till the end. So this reference from Sushruta we can understand in this context. And the uteroplacental circulation after the placental formation will take over the function of corpus luteum. This is also Chetana when it is coming to the Ayurvedic reference. And Agni Mahabhuta, which is very important in the, particularly you can see the reference of Bhava Mishra, the fetal metabolism of the glucose utilization is provided by Agni Mahabhuta. So when this Agni Mahabhuta is normal and active, then this glucose metabolism to the fetus will be properly provided and it will be helping in continuation of the pregnancy. So this is told as Agni Ratra Panchakadi Karma Jivayati. Pachakadi Karmana Jivayati. That is, when Agni is powerful or efficient, this Pachakadi Karmana, that is the metabolism, will be effective and that will promote the Jivayati, continuation or life of the embryo or the pregnancy. So when you see about Apraja, Raktapitta Karainarya Raktam Pittena Doshitam, Atipravartate Yonyam Labde Garbo Apisa Asruja. And Garbo Na Tishtati Apraja Bhavanti. This is Chakrapani reference you can see. Stitam Hanti Garba Putragni Rakta Samsravat. Along with the bleeding, Stitam Hanti Garba, which is getting established, will get lost. So Dushita Sonitajam is also one reference, which these all references are indicating that recurrent pregnancy loss we can consider Apraja and Putragni Yoni Vyapat, etc. So coming to the Nidana, what we have to see according to our science is Midhyachara, that is totally contributing to the maternal factors. Pradushta Artava, maternal, that is corpus luteum insufficiency. Bija Dosha, abnormal karyotyping or chromosomal abnormalities. Bija Bhagava Avayava, that is chromosomal abnormality or aneuploidy. Genetical numerical aneuploidy results from the meiotic non-distinction in the germ cells of couples with normal parental karyotypes. So even though karyotyping is normal, this can result in genetical numerical aneuploidy, that is abnormality of the chromosomes, one additional, one deletion, like that. So this can result from the meiotic non-distinction when the cell division is taking place. When there is a non-distinction or proper division is not taking place in the germ cells, then this can happen leading to the aneuploidy. And these are the some of the causative factors we can see: Midhyachara, Pradushtartava, Bija Dosha and Bija Bhaga Avayava. So these are the factors we can understand in Ayurveda. Finally, coming to the idiopathic category or unexplained, that is Daiva. So these important factors, that is Rutu Kshetra, Ambu, Bija. So Sushruta has clearly told Ruturanganaya Rajas Samaya Kshetram Garbhashaya Ambu Punarahara Pakajo Vyapi Rasadhatu Bijam Sri Pumsayor Artava Shukro. So when the conception take place according to this reference in Rutukala, then only there will be a proper development of the embryo and the fetus and proper continuation of the pregnancy loss. So this is the importance of the Rutukala. Eshu Uttarottaram Vidyat Ayur Arogyam Cha Praja Saubhagyam Aishwaryam Balam Cha Divaseshu Vai. So the proper conception which is happening in the Rutukala, that is luteal, post-luteal phase, we can understand, then only the pregnancy will be sustaining. Otherwise, lack of progesterone or poor response of endometrium to progesterone will not allow the pregnancy to continue. So a classical study published in the New England Journal of Medicine, that is likelihood of miscarriage increased significantly after day 9 of implantation, that is post 11 days, 82%. So this is a fact that is established. So late implantation, Rutu Vyatita Kala, that is even after the 15 or 16 days, sometimes the oocyte will be available and viable after the release after 48 or 72 hours also, but that comes under Rituvyatita Kala. So this will lead to implantation, late implantation defects, that is chromosomal abnormalities. And when smoking and these factors are there, then that will also lead to implantation failure. And Atibala and Ativruddha Varjayet. Always it is said very young girl having sexual intercourse with a Ativruddha, that is more aged person, will lead into the chromosomal abnormalities. So that is also has to be avoided even according to Charaka. So the Kshetra, uterus and adenexa, endometrial receptivity, Ambu is maternal rasadhatu or the continuation Artava, HPO, axis functional integrity, innate immunity, corpus luteum producing progesterone, trophoblastic function, which is giving the HCG. All this comes under Ambu. Hence, spermatozoa and oocyte comes under Bija. So this all has to be addressed and corrected to get a proper continuation of the pregnancy and treat the recurrent pregnancy loss. So in this reference of Charaka, you can see indicating this Purushaya Anupata Retasa Sukrashonita Samsargam Antargarbhashayagatam Sasapya Rasopayogat Arogo Abhivardate Matrujascha Pitrujascha Sattvaja Atmajascha Rasajascha. So this is indicating that when there is an involvement of healthy maternal Matruja, paternal Pitruja, and this Atmaja, genetical Rasaja, cell-mediated immunity, then there will be anti-inflammatory Th2 mediation will be provided, and which promotes the growth and development till the term. Then only there will be proper Sukrashonita Samsarga, and that will be resulting into Arogo Abhivardate, that is without any abnormality, that Garbha will be having Vruddha or the development. So this you can see the importance of here all the maternal, paternal, genetical, cell-mediated immunity factors also to help in the continuation of the pregnancy. So here you can see implantation related is Rutu in the Matruja Bhavas, anatomical related and genetical related Bija and Matruja, Pitruja, Atmaja Bhavas, and immunological related Ambu, Rasaja, Sattvaja, Satmaja, and Atmaja Bhavas. So these four factors you can see here in the formation of the healthy pregnancy. So coming to the Samprapti to understand how you can understand this. So when you take Midyahara Vihara, Pradushta Artava, and also Agnimandyata and Dhatvagnimandyata, you can see Rasadhatu Dushti and Majjadhatu Dushti. This is nothing but imbalance in the cytokines, which will lead to the inflammatory response. And next, coming to the Shed Bhava imbalance, that is nothing but the disturbed cell-mediated immunity because of this imbalance in the cytokines, which is leading to vascular thromboembolism of the uterine vessels, which is leading to the Artavaha Shroto Sangha, or Garbhavruddhi is getting hampered because of the Upasneha is not being done here and Upasveda is not being done. That is, there is no perfusion of the nutrients to the fetus. So this is a Samprapti we have to understand. Imbalance in the cytokines leading to disturbed cell-mediated immunity leading to vascular thrombosis of uterine vessels. When you look into Ayurveda, Midyahara Vihara, Pradushta Artava, Agnimandya, Dhatvagnimandya, Rasadhatu, Majjadhatu, Dushti, leading to Shed Bhava imbalance and leading to Artava Shroto Sangha and hampering the Garbhavruddhi. So these are some of the references of yoga and meditation which help in reducing the DNA damage, oxidative stress, etc., which will help in promoting the successful outcome of the pregnancy. In coming to the conclusion and take-home message of this presentation, this correction of all the factors, that is Rutu, Kshetra, Ambu, Bija has to be done prior to the conception only. Shad Bhava Shuddhi has to be done prior to conception. Garbhadana Vidhi has to be followed, and post-conception Garbhasthapaka Chikitsa and complete Garbhini Paricharya for the 9 months has to be followed to treat the recurrence pregnancy loss. And the unexplained immunological causes, implantation defects are very well tackled with the intervention of Ayurvedic treatment. As I have explained you all the different varieties of treatments, combined effect of post-pregnancy loss management immediately or preconceptional counseling, both together along with antenatal care and counseling, will give 100% a very healthy take-home baby, increase success rate in the recurrent pregnancy loss. So these are some of the references reviewed. Thank you. Any queries are invited. Once again, I am thankful to Param Ayurveda organizers, Dr. Bujbal sir and madam, and also to all the audience for the patience listening. Thank you one and all.
नमो नमः महोदया। बहुत ही ज्ञानपूर्ण और अनुभव संपन्न आपका व्याख्यान रहा। आरंभ से लेकर टेक होम मैसेज तक पूरे के पूरे सभी स्लाइड्स और उस पर आपका वक्तव्य, हर एक शब्द व्यवहार्य था। चिकित्सालय में चिकित्सा करते वक्त आपका ये मार्गदर्शन जरूर ही सभी वैद्यों के लिए पथदर्शक रहेगा। तो इतनी सुंदर प्रस्तुति के लिए मैं आपको सादर प्रणाम करती हूँ और आपका अभिनंदन भी करती हूँ। पुत्रीय विधि भी आपने बहुत मतलब एक ही स्लाइड में इतना बड़ा सब्जेक्ट आपने इतने सुंदर तरीके से रखा है, वो मुझे बहुत अच्छा लगा। साथ ही में मंत्र योग का भी आपने विथ रेफरेंसेस साइंटिफिक जर्नल पब्लिकेशंस के साथ जो भी सामने रखा है, तो वो भी हम वैद्य अगर सभी आयुर्वेदिक चिकित्सा के साथ इसका प्रयोग करें तो उसका ज्यादा अच्छा असर हमें उत्तम संतान प्राप्ति के हेतु तथा सर्वोच्च नागरिक भारत के हम प्राप्त करने हेतु अपना योगदान दे पाएंगे। तो पुनश्च आपको धन्यवाद देती हूँ। मैडम के इस व्याख्यान के संदर्भ में अगर उपस्थित वैद्यों में किसी को कोई शंका हो तो वे जरूर पूछ सकते हैं। मैं एक प्रश्न पूछना चाहती हूँ। पुत्रीय विधि में संशोधन से लेकर क्षेत्र तैयारी तक उसके कालावधि का कुछ आपका अनुभव शेयर करेंगे कि कितना देना चाहिए या आइडियल होना चाहिए?
नहीं, जैसा हम आमपाचन से शुरुआत में स्टार्ट करते हैं तो उस हिसाब से एटलीस्ट मिनिमम 1 वीक तो आमपाचन देना पड़ेगा। देन ईच एंड एवरी शोधना दैट विल टेक देयर ओन कोर्स। लाइक फॉर एग्जांपल आप विरेचन दे रहे तो मिनिमम तो 3 दिन स्नेहपान टिल द स्नेह लक्षणास आर विजिबल स्नेहपान देंगे। देन बाद में स्वेदन, देन विरेचन, देन संसर्जन क्रम पूरा होने तक एटलीस्ट 15 दिन वेट करना पड़ेगा। देन उसके बाद ही देन फर्दर ट्रीटमेंट लाइक योग बस्ती विल बी गिवन। अगेन आफ्टर दैट संसर्जन क्रम एंड जनरली वी कंबाइन उत्तर बस्ती along with योग बस्ती शेड्यूल। सो वहाँ टाइम थोड़ा बच जाता है, बट एटलीस्ट इट विल टेक मिनिमम 1 to 1.5 month पीरियड टोटल।
जी धन्यवाद महोदया। एक प्रश्न है, कैन यू टेल मोर अबाउट द्राक्षादी चूर्ण?
Yeah, sure. This is one of the preparation Probably the main reference is from Ashtanga Hridaya they have taken. There is a text called Basavarajiyam. That is a text which is written by a South Indian author. But the Basavarajiyam text Hindi version, Devanagari version is also available. So in that, this reference is given Drakshadi Churna, and it has got a very almost like 60 to 70 drug combination it is, and this is commercially prepared by a pharmacy called Chintaluru. So this is very, actually the reference itself is indicating that Mrutavatsa, that is given in the Mrutavatsa. So we can adopt it in the recurrent pregnancy loss. So for the individual drug details, you can refer Basavarajiam text.
जी धन्यवाद। और हम आरपीएल में द्राक्षा का सेवन आहार में भी कर सकते हैं ना, काले मुनक्का का?
Definitely that can be given.
Yes. धन्यवाद महोदया, बहुत सुंदर लगा आपका ये व्याख्यान। तो आपसे ऐसे ही आगे भी अन्य विषयों से लेकर आपसे जुड़े रहेंगे। तब तक के लिए आपकी अनुमति हो तो इस व्याख्यान को हम यहीं पर समाप्त करेंगे।
Thank you so much.
पुनर्मिलामः, धन्यवादः।
सकते नहीं।
You in position yet? Working on it.
हम देवों का निर्णय है कि उचित समय आने तक उसकी शक्ति।
हे गणेश महाराज, मैंने सुना है कि यदि कलंक चतुर्थी के दिन कोई चंद्रमा के दर्शन कर ले तो उस पर कलंक लगने से आपकी पूजा अर्चना बचा सकती है। अतः देखिए, मैंने आपके लिए कितने सारे लड्डू बनाए हैं। मेरे पति पर कलंक लगने से बचा लीजिए उन्हें।
हे गणपति महाराज,
अरे क्या हुआ?
हे विनायक महाराज,
बताइए तो हुआ क्या है?
क्षमा करो, कृपा करो और मुझे इस कलंक से मुक्ति दिलाओ, मुक्ति दिलाओ।
देखा, लग गया ना कलंक, कहा था मैंने। हे गणेश जी, अब क्या होगा?
हम अनभिज्ञ नहीं है, न ही आपके द्वारा रचे गए षड्यंत्र से और न ही इस सत्य से कि आप अपनी महत्वाकांक्षाओं के लिए अपने ही पति के विरोध षड्यंत्र रचकर उन्हें सिंहासन से हटा दिया।
महारानी, ये सत्य है क्या?
न ही इस सत्य से हम विज्ञ हैं कि आपने महाराज के साथ विवाह इसी कारण किया ताकि आपकी आकांक्षाओं के परों को उड़ने का खुला आसमान मिल जाए।
महारानी, ये भी सत्य है क्या?
आपके लिए संबंधों का नहीं, मात्र अवसर का मोल है जो आप कभी चूकने नहीं देती।
नहीं नहीं नहीं, ऐसा नहीं हो सकता गुरुदेव। महारानी, ये भी सत्य है क्या?
आप शांत हो जाइए। आप भले ही प्रलयंकर जी के गुरु हो, आप भले ही सर्वज्ञाता होंगे, किंतु स्मरण रखिएगा, हम विजयनगर की महारानी हैं।
क्षमा चाहते हैं महारानी, किंतु ये अटल सत्य है कि सत्य कटु होता है। परंतु मुझसे इतना सब कुछ सुनने के बाद आपको ये तो ज्ञात हो ही गया होगा कि हम कोई साधारण से गुरु नहीं है। अतः हमारी प्रत्येक बात को गंभीरता से लीजिएगा।
गुरुदेव, यदि ये अनुमति हो तो हम एक सुझाव दें।
अनुमति है
गुरुदेव। यदि आपकी अनुमति हो तो पंडित रामाकृष्णा के लिए अगली चुनौती हम निर्धारित करें।
अरे अम्मा 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 सुनो, देखो देखो मेरी बात तो सुनो, मुझे क्षमा कर दो। मैं क्या बोल रहा हूँ, देखो तुम। अम्मा मुझसे भूल हो गई, मेरी बात तो सुनो।
आज तो नहीं छोड़ूंगी तुझे, जब देखो अपनी मनमानी करता रहता है।
शादा शादा शादा, तुम मेरी बात तो
आप मेरी कोई भी बात नहीं मानते हो।
अरे बचाओ, अरे कोई तो रक्षा करो मेरी। पुत्री, ये क्या कर रहे हो तुम दोनों?
मार रहे हैं।
अरे क्यों? जिनका गुणगान होना चाहिए उनकी डंडे से पिटाई हो रही है। बापू चुनौती जीत चुके हैं। हाँ शारदा माँ, तुम्हारे पति ने आज दरबार में सबको मौन कर दिया। बुद्धि का ऐसा प्रदर्शन किया कि सब आश्चर्यचकित रह गए। देखा भास्कर, मार मार कर बुरा हाल कर दिया मेरा। मैं यहाँ चुनौती जीत कर आया हूँ और ये सम्मान दे रही है घर की दोनों स्त्रियाँ मुझे। नहीं बापू, मुझे तो तुम पर गर्व है कि मैं तुम्हारी संतान हूँ। देखा, सीखो कुछ। मुझे भी तुझ पर गर्व है भास्कर कि तू मेरा पुत्र है। आज दरबार में इसने सबको आश्चर्यचकित कर दिया। उद्घारे तो तुमने किया है, तुमने दरबार में सबको आश्चर्यचकित करके रख दिया। तुम महान हो। अरे आश्चर्यचकित तो तूने कर दिया, तू भी कुछ कम नहीं है। नहीं, तुम कम नहीं हो, तुम महान है। तुम महान हो बापू। अरे तू महान है। नहीं नहीं, तुम महान हो बापू। तुम महान है।
अरे बस बस बस, अभिषेक देखो और पुत्र अपनी प्रशंसा कर रहे हैं।
चल इस शुभ अवसर पर मुंह मीठा करते हैं, कुछ मिष्ठान हो जाए। लड्डू नहीं, मोतीचूर के लड्डू। मैं लड्डू। देखा अपनी लालची दादी अम्मा को। भास्कर, कुछ समझ नहीं आ रहा कि इतना नन्हा सा बालक इतना बुद्धिमान कैसे हो सकता है। मुझे संशय है कि उसे विजयनगर लाया गया है, वो स्वयं नहीं आया। कोई और नहीं बापू, इसे तो अवश्य ही प्रलयंकर लेकर आया होगा। संदेह तो मुझे भी है। कुछ सोच भास्कर, कुछ सोच कि कैसे इस बालक का सत्य ज्ञात किया जाए।
46, 47, 48। धनी।
हाँ गुरुजी, बताइए क्या कह रहे हो?
49। मनी।
जी गुरुजी।
50। सुधर जाओ तुम दोनों, अन्यथा तुम दोनों को कठोरतम दंड मिलेगा। कौन है? कौन हो देवी तुम?
देवी नहीं, मंदाकिनी। घर के पीछे आकर भेंट करो, मैं प्रतीक्षा कर रही हूँ।
मंदू, 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 तेरे द्वार खड़ा है जोगी, जो है तेरा प्रेम रोगी। घड़ी मिलन की आई।
गए मंदू के प्रेमी। मंदू, मंदू, मंदू।
भास्कर पता नहीं कहाँ रह गया, कितना समय हो गया। यदि हमारे पिताश्री ने देख लिया तो अत्यंत।
दाता मार्ग में थे ही नहीं। हाँ, अच्छा तुम ये बताओ, तुम यहाँ खड़ी होकर मेरी प्रतीक्षा कर रही थी ना?
हम तुम्हारी प्रतीक्षा थोड़ी ना कर रहे थे, हम तो अपने सूरज की प्रतीक्षा कर रहे थे।
सूरज? ये सूरज कौन है?
जिसने हमारा हृदय चुरा लिया है वही।
वो तेरी हृदय भी चुरा लिया? कौन है सूरज? उसे अभी के अभी मेरे सामने लेकर आओ तुम।
हम तुम्हें तुम्हारे सामने कैसे लेके आ जाए? हमारा कहने का तात्पर्य ये है कि हमारे सूरज तो तुम ही हो, और भास्कर का अर्थ सूरज ही तो होता है ना?
तेरी, तुम तो मेरी संगत में रहकर बड़ी चतुर हो गई।
हाँ हाँ, कैसे ना होंगे।
किंतु अब तुम्हें थोड़ी और चतुराई दिखानी पड़ेगी आम्रपाली। मुझे तुम्हारी सहायता की आवश्यकता है। देखो, मैं जानता हूँ कि तुम प्रलयंकर के साथ कोई संबंध नहीं रखना चाहती, किंतु वो है तो तुम्हारा भाई ही ना। बस मुझे तुमसे सहायता ये चाहिए कि तुम उसके प्रति बहन का प्रेम दिखाकर उसके समीप जाओ।
किंतु हम ये कैसे करेंगे भास्कर?
आम्रपाली, हमें संदेह है कि उस बालक राघवन को प्रलयंकर ही यहाँ लेकर आया है। तुम्हें केवल ये ज्ञात करना है कि वो राघवन बापू के समक्ष दूसरी चुनौती कौन सी रखने वाला है, और विजयनगर आने के पीछे उसका असली प्रयोजन क्या है।
परंतु भास्कर, हम अपने भ्राता के साथ कोई भी संबंध नहीं रखना चाहते। संबंधों पर विश्वास करना हमारे लिए अत्यंत कठिन है भास्कर। हमें नहीं।
मुझे ज्ञात है आम्रपाली, ज्ञात है मुझे, किंतु हमें कुछ कार्य व्यक्तिगत संबंधों से ऊपर उठकर राज्य के लिए करने पड़ते हैं। तुम्हें मुझ पर भरोसा तो है ना? विश्वास है ना मुझ पर?
भास्कर, हमें तुम पर पूरा विश्वास है, परंतु
बस, जब विश्वास है तो परंतु का कोई स्थान ही नहीं।
तुम जैसा कहोगे ना, हम बिल्कुल वैसा करेंगे। किंतु हमारी एक शर्त है।
कैसी शर्त?
यही शर्त कि तुम्हें अभी इसी वक्त हमारे समक्ष प्रणय निवेदन करना होगा अपने प्रेम का।
जब से तुम्हारा सुंदरतम मुखड़ा देखा है, तब से निद्रा में भी तुम्हें देखता हूँ, आंखें खोलता हूँ तो भी तुम्हें देखता हूँ। मेरे हृदय में तुम्हारे प्रति प्रेम की नदी बहती रहती है। काजल से भरे तुम्हारे नेत्रों में मैं डूब जाना चाहता हूँ।
हमारे अधरों के विषय में कुछ नहीं कहोगे?
तुम्हारे अधर तो गुलाब की पंखुड़ियों की बात।
ऐसे टुकुर टुकुर क्या देख रहे हो? हमारा ये डंडा तुम्हारी हड्डियां तोड़ने के लिए लालायित है, किंतु हम समझ नहीं पा रहे हैं कि तुम्हें कैसे पीटें और कहां से पीटें।
तुम भास्कर ये लो और हमारे गुरुजी की दुविधा को समाप्त करो, अर्थात इस डंडे से पीट पीट के ये समझाओ कि ये तुम्हें कैसे पीटेंगे, और ये भी बताओ कि कहां कहां पीटना है।
अरे बापू, तुम!
बापू! भाग गया, भाग गया, भाग गया, भाग गया।
भाग गया गुरुजी।
हाँ, भाग गया। तुम दोनों के कारण भाग गया। अब हम तुम्हें बताएंगे कैसे पीटेंगे, कहां पीटेंगे।
आइए पंडित रामाकृष्ण।
मेरे आगमन की आहट से परिचित हो, अब ये मत कहना।
नहीं कहेंगे पंडित रामाकृष्ण, क्योंकि आपके आगमन की सूचना हमें वो सामने लगे हुए आयने ने दी है।
तुम्हारी बुद्धि की जितनी प्रशंसा की जाए उतनी कम है। अद्भुत हो तुम। क्या चुनौती दी थी मुझे। सत्य कहूं तो मुझे स्वयं विश्वास नहीं था कि मैं तुम्हारी दी गई चुनौती को पूर्ण कर पाऊंगा। अब भय लग रहा है कि पता नहीं अगला प्रश्न कौन सा करोगे, कैसी चुनौती रख दोगे मेरे समक्ष। अवश्य ही अत्यंत कठिन होगी ना।
हाँ, इतनी कठिन जितनी आप सोच भी नहीं सकते।
अवश्य। वैसे ये ज्ञात नहीं कि हम दोनों का साथ कब तक बना रहेगा विजयनगर में, क्योंकि तुमसे पराजित होकर तो मैं विजयनगर से निष्कासित कर दिया जाऊंगा। अतः मैं चाहता हूं कि हम दोनों की इस भेंट की एक स्मृति बनवाई जाए। मैं एक चित्रकार को अपने संग लाया हूं, ताकि संसार के सर्वश्रेष्ठ बुद्धिमान व्यक्ति के साथ मेरा एक चित्र बन जाए।
अवश्य बनवाइए। हमारी स्मृति को देखकर हमें याद जरूर कीजिएगा।
हाँ। राजेश्वर, विजयनगर के सर्वोत्कृष्ट चित्रकारों में से एक है ये।
ये क्या चित्रकार है पंडित रामाकृष्ण? नीचे उतारो हमें।
अरे तुम बालक हो, इस प्रकार मेरी गोद में चित्र बनवाओगी ना तो बहुत अच्छा लगेगा।
हम कोई बालक नहीं है जिसको तुमने अपनी गोद में उठा के रखा है। नीचे उतारो हमें। हमने कहा नीचे उतारो।
कद काठी से, स्वरूप से बालक ही तो लगते हो, फिर ऐसा क्यों कहा कि मैं बालक नहीं हूं?
हमारे कहने का अर्थ है कि बालक वो होता है जिसके भीतर बच्चों जैसा मस्तिष्क होता है, और हमारी बुद्धि किसी विद्वान व्यक्ति से कम नहीं। अतः हम स्वयं को बालक नहीं मानते। और हाँ पंडित रामाकृष्ण, पुनः हमें स्पर्श करने का दुस्साहस मत कीजिएगा।
रामा, वो बालक तुझे डांट के गया और तू मुस्कुरा रहा है।
बंधु, ये बालक मुझसे जो कुछ भी छिपाने का प्रयास कर रहा है ना, वो तो मैं ज्ञात कर लूंगा। अब मेरी दृष्टि इस बालक पर ऐसे रहेगी जैसे एक चील की होती है अपने शिकार पर।
आज किसी भी स्थिति में पंडित रामाकृष्ण की पराजय होनी चाहिए। पंडित रामाकृष्ण को ऐसी चुनौती दीजिए जिसे सुनकर उनकी आत्मा कांप उठे।
ये चील तो अपना शिकार करके ही मानेगी। तो अब पंडित रामाकृष्ण के विजयनगर से निष्कासन करने की तैयारियां प्रारंभ की जाए। अब जल्द ही पंडित रामाकृष्ण से विद्वान तथा पंडित होने की उपाधि छिन जाएगी।
पंडित रामाकृष्ण जी, हमें पूर्ण विश्वास है कि आज आपको मिलने वाली नई चुनौती में आप सफल होंगे। आपको हमारी शुभकामनाएं हैं।
धन्यवाद महारानी जी।
ये चील दरबार के अंदर कैसे आ गई? सैनिकों, इसे बाहर निकालो। ये कैसा परिहास है?
ये कोई परिहास नहीं महारानी, अभी तो यही तो है पंडित रामकृष्ण की अगली चुनौती।
हो, ये चुनौती है। कोई बात नहीं, मैं अभी इस चील को उड़ाकर दरबार से बाहर भगा देता हूँ।
याद रहे पंडित रामकृष्ण, आपकी प्रथम चुनौती से कई गुना ज्यादा कठिन है ये चुनौती। आपको इस चील को उड़ाकर नहीं दिखाना है, अभी तो इस चील से ऊपर उठ के दिखाना है।
अब चील से भी ऊपर उड़कर दिखाना, ये तो असंभव है। ये बेचारे पंडित रामकृष्ण, अब इनके पर तो है नहीं कि यूं पर फड़फड़ाएंगे और चील के ऊपर उड़ के दिखा देंगे।
गुरुजी, कोई और कर सके या ना कर सके, किंतु आप तो शिव जी के परम भक्त हैं, आप तो कर ही सकते हैं।
इसलिए आपको करके दिखाना चाहिए गुरुजी। आप अंदर अपनी चोंच बीच में मत डालो।
सत्य कथन है राजगुरु जी का, ये तो पंडित रामकृष्ण जी के साथ अन्याय हो रहा है। ऐसे कोई कैसे उड़ सकता है, वो भी चील से भी ऊपर? हमारी आपसे विनती है, आप पंडित रामकृष्ण जी पर थोड़ी दया दिखाइए, उन पर अत्याचार मत कीजिए। वो ब्राह्मण हैं, पूजनीय हैं, विजयनगर के प्रिय हैं, परंतु भगवान नहीं है। ये कार्य करना उनके लिए असंभव है।
हाँ, ये कैसे संभव होगा? हाँ, पंडित रामकृष्ण जी कैसे उनके दिखाएंगे? कैसे संभव होगा?
रामा, तू चील से ऊपर कैसे उड़ेगा? ये तो असंभव सा प्रतीत हो रहा है।
असंभव नहीं है। यदि पंडित रामकृष्ण पराजय स्वीकार करते हैं तो हम इस कार्य को करके दिखा सकते हैं।
क्या? फिर तो ये विजयनगर की प्रतिष्ठा का प्रश्न है। यदि आप इस कृत्य को कर सकते हैं तो पंडित रामकृष्ण क्यों नहीं?
For more updates, subscribe to our channel, click the show links and enjoy watching the videos.
हम देवों का निर्णय है कि उचित समय आने तक उसकी शक्ति
चील तो इतना ऊपर उड़ चुकी है जहां तक दृष्टि भी नहीं जा रही है। अब चील से भी ऊपर उड़कर दिखाना, ये तो असंभव है।
कल प्रातःकाल तक यदि आप ये कार्य पूर्ण नहीं कर पाए तो हम संसार त्याग देंगे और उसका दोष